All right. Hello, everyone. Welcome to our CaTS Lunchtime Seminar Series. Just a few housekeeping announcements and about questions. During the talk, please be sure to mute yourselves and type your questions in the chat window. We'll save time at the end to answer questions if you'd rather unmute yourself and ask your question in person. So today we have Dr. Justin Brown joining us. Dr. Brown is an assistant professor and director of the Cancer Metabolism Program and the Cancer Energetics Laboratory at Pennington Biomedical Center. His research largely focuses on the mechanisms through which weight management, diabetes control, optimal nutrition, and physical activity prevent the development and progression of cancer. Today, Dr. Brown is going to be discussing the role of physical activity in colon cancer survivorship, leveraging observational studies to inform clinical trial design. Thanks, Dr. Brown. I'll go ahead and pass the mic over to you.
Thank you so much, and thank you to CaTS for the very kind invitation to be able to present on one of our recent publications and a newly funded trial in physical activity and colon cancer survivorship. I do have to disclose that I receive grant funding from the National Cancer Institute, Cancer Research United Kingdom, and the American Institute for Cancer Research that is paid to Pennington Biomedical Research Center. So hopefully by the end of this seminar, you'll be able to do the following: be able to describe the benefit of using observational data to justify and inform the design of randomized trials, to compare the strengths and weaknesses of different sources of observational data, and recognize that modifiable lifestyle factors such as physical activity have an important impact on how cancer survivors feel, function, and survive. So most of my talk today will be in patients with stage 3 colon cancer. This is a very common malignancy, and these patients are typically treated with surgery followed by chemotherapy. But unfortunately, about 1 in 3 patients will have their colon cancer come back. They'll experience disease recurrence. And this is problematic because the nature in which colon cancer tends to return, it's often in the liver and the lungs, it's metastatic, and often the best that we can do is prolong life rather than try to recure patients. And so the median survival after recurrence for most patients is between 24 and 36 months. So there's a lot of interest in being able to identify additional therapies that can be added to chemotherapy in order to try to improve the probability of cure for this very common malignancy. And so I'm going to talk about this trial today. This is Cancer and Leukemia Group B, Southwest Oncology Group. It's trial 8702, and it was a 2x2 factorial trial. It was a phase 3 randomized trial that had 2 randomizations. The first randomization was to either placebo, so these 2 groups got a placebo and they took placebo daily for 3 years, or the anti-inflammatory medication celecoxib. It was 400 milligrams daily and they took celecoxib for 3 years. This was the primary comparison of trial 8702. The second randomization was testing whether 3 months of chemotherapy is non-inferior to 6 months of chemotherapy. And this is out of recognition that treatment in oncology is really trying to balance toxicity from chemotherapy versus the probability of cure. And so this randomization was pre-specified to contribute to an international pooling consortium in order to test the non-inferiority of 3 months versus 6 months of chemotherapy. And the primary endpoint was disease-free survival. So the superiority of celecoxib versus placebo on disease-free survival was not proven, and that was the primary outcome of this trial, and it was published last year in JAMA. And the non-inferiority of 3 versus 6 months of chemotherapy was proven for patients who had a low risk of cancer recurrence. It was not proven for patients who had a high probability of recurrence, and those patients continue to get 6 months of chemotherapy. And this paper was published in the New England Journal. So at this point, you might be asking yourself, I thought he was going to talk about observational data. He's talking about randomized clinical trials. But what we did is we nested an observational cohort cohort study within this randomized trial. And what we did is at the time subjects were recruited, we asked them if they would like to participate in a lifestyle sub-study. And about 1,700 patients agreed to enroll in the lifestyle sub-study. And what it required was completing a questionnaire that assessed diet and lifestyle at the time of trial enrollment, as well as after patients finish their chemotherapy about a year later. And so the key strengths of embedding an observational cohort study within a randomized trial is you have to do it prospectively. So we had pre-specified hypotheses that we want to test by adding diet and lifestyle questionnaires into this randomized trial. The benefit of a randomized trial is some people are eligible and some people aren't eligible. So it creates a homogeneous subject pool. The third is that the treatment and the follow-up and the endpoint measures in this randomized trial were standardized. That is, everybody had to do the same treatments at the same time points, had the same follow-up to assess disease recurrence, and the disease-free survival endpoint was measured in the same way across all subjects. And as an epidemiologist, what I'm trying to do is estimate causal effects of some exposure on an outcome. And in order to do that, you have to collect confounder data. And so by having this pre-specified study design, we were able to collect specific confounding variables so that we could feel confident that the associations we were quantifying between physical activity and disease-free survival had a causal interpretation. And the benefit of nesting an observational study in a randomized trial is you have all of these benefits versus, say, using electronic medical record data, where it's often retrospective. The patients reflect the diversity of the community. A lot of the treatment and follow-up and measurement of outcomes is done differently by different providers. And often when we try to estimate causal effects, we would love to have certain confounding variables, and they're just not available. And so our ability to make convincing inferences from the data is somewhat limited. And so subjects recruited from this study were enrolled at 654 clinical sites across the United States and Canada. So you might be asking yourself, how do you assess lifestyle at all of these different sites? And really, it was a simple paper and pencil booklet that subjects were given at the time that they enrolled in the study. And we measured physical activity with this Scantron form here. This might take you, you might have a flashback to being in high school all over again. But we asked about different types of physical activity that was done in the past 2 months. And then we also asked the frequency or the time with which those activities were done throughout the week. We also assessed diet using a food frequency questionnaire that asks about a variety of common foods. And we had height and body weight that were measured in the clinic, in addition to a variety of other measures that were included. And so the main paper from this analysis was just published in the Journal of Clinical Oncology. And I'm very happy that the Journal of Clinical Oncology published it because a lot of the readership of this journal are clinicians that are in the community practicing oncology, practicing medicine. And what this does is it helps to further legitimize the importance of physical activity and lifestyle more broadly, that these factors have very important implications for a patient's ability to live as long and as healthy as possible. So this paper was published about a month and a half ago. And so the original parent trial, that's the intention to treat sample, recruited 2,524 subjects. And here's some of the very basic characteristics regarding their age, their sex distribution, and this is their risk of recurrence. This is the people who had a lower risk of recurrence and those who had a higher risk of recurrence. And you can see not everyone participated in the lifestyle sub-study. It was an elective study that patients could enroll into, but generally speaking, they look similar to the overall sample. We were not able to detect any systematic differences in the subjects who participated in the sub-study versus the overall sample, and we looked at a variety of characteristics beyond those that are presented here. So this was the main analysis. And when we measure physical activity, we quantify it in terms of METs. And METs is basically, you can think about it as energy expenditure. So it's the amount of energy that you expend per week doing activity activity. So this group, less than 3 met hours per week, is about 1 hour of brisk walking over the week. So people in this category reported an average energy expenditure consistent with 1 hour or less of brisk walking weekly. Conversely, patients in this category, greater than or equal to 18, did about 6 hours per week of brisk walking. So 1 hour per day, 6 days per week. And you can see here, this is the 3-year disease-free survival rate. So 76.5% of the subjects in this group at 3 years were alive and cancer-free. And you can see that it slowly increases as the physical activity energy expenditure increases. And so comparing the low active versus high active group, the absolute risk difference in disease-free survival at 3 years is almost 11 absolute percentage points. And you can see here, this is the hazard ratio. Those that did more physical activity had a 48% lower likelihood of having a disease recurrence or death during the follow-up period. And that was statistically significant. And the PAR is an epidemiologic approach to quantify the population attributable risk. So what this is trying to do is think about a hypothetical scenario where if we were able to take every stage 3 colon cancer survivor and increase their physical activity by 1 category. So if we got the people in this less than 3 to be in this category, and we got the people that used to be in this category to be in this category, how many disease recurrences and deaths could we theoretically prevent? And so by doing this, we can quantify the population benefit of improving physical activity in this population. And our estimate was that 22% of cancer recurrences and premature deaths could theoretically be prevented if every patient increased their physical activity level by 1 category. And during this analysis, we also found another very interesting finding, and that was patients who did more physical activity at the start of the study were able to receive more of their intended chemotherapy. So at the start of the study, every patient received the same dose of chemotherapy. It was standardized to their body size. But as patients have toxicities, and side effects from chemotherapy, the oncologist has to reduce the dose of chemotherapy. And the 2 main drugs that are used for the treatment of colorectal cancer is 5-fluorouracil, it's a fluoropyrimidine, and oxaliplatin, it's a platinum agent. And you can see that compared to those who did very little activity, as physical activity went up, particularly in this 9 to 17.9 range, they had a statistically significant higher ability to tolerate more chemotherapy, both for 5-fluorouracil as well as for oxaliplatin. However, the highest group, the group that did the most activity, they did not experience the same benefit in terms of relative dose intensity of chemotherapy. And so what this indicates is that there may be a sweet spot. There may be a situation where some activity is good, but if you do too much, you actually get diminishing returns. And so this is relevant because we know that chemotherapy relative dose intensity in patients with stage 2 and stage 3 colon cancer is directly related to their probability of remaining alive. And so what this graph shows is on the x-axis is the chemotherapy relative dose intensity. So patients at 100% received exactly what the clinical guidelines said they should have received. And patients that receive lower than 100% are patients who likely had side effects that required their oncologist to either dose reduce their chemotherapy, to skip a dose, to delay a dose, or eventually to stop chemotherapy entirely. And you can see that as the chemotherapy relative dose intensity declines, the risk of dying from any cause goes up, such that for each 1% in chemotherapy relative dose intensity, the risk of death goes up by about 3 percentage points on a relative scale. So this highlights that small changes in a patient's ability to tolerate chemotherapy could have major implications for their ability to remain alive and potentially remain disease-free. And so it was this data that formed the foundation for our newly funded trial by the National Cancer Institute. And this trial is titled Adaptive Randomization of Aerobic Exercise During Chemotherapy in Colon Cancer. And we refer to this as the ACTION trial. And this trial is a multi-center trial that is part of the INIGDO consortium, and INIGDO stands for the Exercise and Nutrition Interventions to Improve Cancer Treatment-Related Outcomes. So this is a consortium of different randomized trials, some of which are focused on exercise or physical activity, like our trial. Some are focused on healthy eating, some are focused on weight management, and some do a combination of a couple different lifestyle modalities. The overarching objective of what we're trying to do in action is to identify the optimal dose of aerobic exercise that improves chemotherapy relative dose intensity in colon cancer survivors. And a lot of the rationale for why we designed this clinical trial the way we did was based on the observational data that I just showed you. And so the ACTION trial uses a Bayesian multi-stage response adaptive dose ranging design. So we will recruit up to 219 patients who have colon cancer that was staged after surgery as being either stage 2 and needing chemotherapy, or stage 3 where chemotherapy is the standard. They haven't yet started chemotherapy, but they do plan to begin, and they are physically inactive. That is, they report not engaging in sufficient physical activity. We will use adaptive randomization to assign subjects to one of 5 different treatment groups, and I'll describe adaptive randomization in a couple slides. But basically, the different groups are an attention control group that's asked to do a stretching program. We did not think that the stretching program would have a causal effect on a patient's ability to tolerate chemotherapy, but it does mimic the behavioral attention that the exercise groups get. And the 4 exercise groups are, it's a moderate intensity aerobic activity at either 75 minutes per week, 150 minutes per week, 225 minutes per week, or 300 minutes per week. And this roughly corresponds to the different categories that I showed you earlier in the observational analysis. And the study is designed so that patients will begin exercise before they begin chemotherapy, and then they will continue their exercise program until they finish chemotherapy. And the primary outcome is chemotherapy relative dose intensity, and the key secondary outcome is patient-reported toxicities. So how patients feel is critical in addition to how much chemotherapy they're able to tolerate. We'll also measure body composition, and one of the hypothesized mechanisms through which we think exercise may improve a patient's ability to tolerate chemotherapy is through neutrophil function, that is preventing patients from developing neutropenia, which is a very common hematologic toxicity, often requiring either dose reductions or dose delays of chemotherapy. And we also are going to measure some other exploratory outcomes that are relevant to patient quality of life as well as their fitness capacity. And so this, again, is a multi-center trial. Patients are recruited from a couple sites throughout the United States, but the exercise program is delivered centrally from Pennington Biomedical, and that's to be able to standardize the delivery of this, what is a fairly complex behavioral intervention. Exercise is very complex to deliver. And so we will give subjects a treadmill, and it's delivered to and set up in their home. They get to keep it. And this is given as a tool to be able to help participants achieve their exercise goals. We also give them a polar heart rate strap that they wear during exercise, as well as a watch. And what this does is it each minute that they're doing exercise, it takes a snapshot of what the heart rate is. And so what this will do is it will allow us to have objective confirmation that subjects in the study are actually doing the amount and intensity of aerobic exercise that they need to do. So everything up to this point has been pretty standard, but when we design clinical trials, we have a lot of uncertainty about key trial design parameters. For example, what is the optimal dose, or what is the optimal endpoint, or what is the optimal population that we want to recruit? And traditionally, we have to make all of these decisions up front at the start of a study, we write them down in a protocol, and then we implement the protocol. Because if we change key trial parameters, we won't know what the data mean at the end of the study in terms of your type 1 and your type 2 error rates. But adaptive trials, what they do is they embrace the idea of continuous learning while you're actually collecting data in the trial that you're going to change some decisions about. And so our uncertainty when we were designing this trial is, what is the optimal dose of exercise to give people? A lower dose is probably more convenient. It's less time exercising, but it may not be as efficacious. Conversely, more exercise may be efficacious, but it might not be feasible for patients to do. So we said, why would we force ourselves to make a decision now when we don't know what the right decision is? Let's collect data, and then we can tailor our clinical trial design based on what the data are telling us and still be able to make valid inferences at the end of the day. So this is how Bayesian adaptive randomization works. So at the start of the study, we enroll subjects, and those subjects are randomized in an equal probability to one of the 5 treatment arms. As subjects begin their exercise and begin chemotherapy, we record how they tolerate their chemotherapy. We update our trial database, and then the statistician fits a statistical model to the data and basically asks the question, how are the different treatment assignments doing at improving chemotherapy RDI? And you get to a termination rule where you could either stop for efficacy. One intervention is doing so well, there's no need to continue further. You could stop for futility. No matter what you do, you won't show a benefit. Or you can stop for harm. That is, you found some safety signal that you couldn't ethically proceed. The alternative is you don't get to a termination rule and you continue with your recruitment of subjects. And so what this adaptive randomization does is it looks at the data and it says, how are these different treatment arms performing? And if one treatment arm looks like it's performing better than another treatment arm, future subjects have a preference to be randomized to that better performing treatment arm. And so what you do is you iterate through this cycle as subjects are recruited onto the trial. So we'll recruit up to 219 subjects. The first 80 subjects will be randomized in an equal probability to one of the 5 groups. And then we will fit our model. We'll decide if we get to a termination rule. If we don't get to a termination rule, we update the randomization weights, and then we recruit 25 more subjects. We cycle through until we either get to a termination rule or we've recruited the maximum number of subjects that we can afford. That is 219. And so the beauty of adaptive randomization is it actually builds in and leverages the uncertainty about one of your key trial design parameters. And by allowing this flexibility to be built into the trial, it improves the probability that your trial actually produces the right answer at the end of the day, because you've acknowledged the uncertainty and you allow the data to help guide your decision making. And so I aspire that the action trial will be able to definitively identify an exercise prescription that has a high probability of clinical benefit. That is, it improves chemotherapy RDI, and we know that higher chemotherapy RDI is associated with improved overall survival. We think the action trial will help to inform clinical guidelines that recognize exercise as an essential supportive care intervention. That is, if you're going to get chemotherapy, you should be getting exercise, and really help to establish exercise as being obligatory for being able to deliver high quality evidence-based care to colon cancer survivors. So my hope is that by listening to me talk, you're now able to describe the benefit of using observational data to justify and inform the design of clinical trials. And I hope that, although I've given the example of physical activity and cancer, you are able to take the lessons I've provided and apply it to your own field, whether it's a drug or a different population or a different surgical procedure. I hope I've provided a framework that might be valuable to guide your thinking. Also, to be able to compare the strengths and weaknesses of different sources of observational data, that is, embedding observational studies in randomized trials versus using other sources such as the electronic medical record. And also, I hope that you've recognized that modifiable lifestyle factors such as physical activity have an important impact on how cancer survivors feel, function, and survive. And so I'll leave you with this. My friend made this now quite many years ago, and I think that this image really encapsulates my life's work, and that's really to be able to develop the evidence base so that patients understand how the choices that they make outside of the oncology clinic, that is, what they eat, how much they exercise, how much they weigh, has a profound impact on how well they are able to live and function, as well as ultimately survive after a diagnosis of cancer. So with that, I will stop. I am happy to take any questions, and I hope that this was valuable to you all. And again, I want to thank you for the invitation. Thank you for your time, and thank you to CaTS for providing me this platform to talk about our recent publication, as well as our exciting trial that we hope to launch this fall. Thank you.
Thank you so much, Dr. Brown. Do we have any questions?
I've left you all speechless. I'm okay with that, actually, but I will say, if you eventually find your speech, I'm happy to reply to email, or if somebody wants to talk. I think Casey can share my contact information. I'm happy to talk to you if you have any interest in the type of work that I do, or if you just want to talk about study design methods or observational design methods. However, I can be helpful.
Yeah, I can absolutely share your contact information. I do have one question, actually. So everyone in your study gets a treadmill. I was wondering if there was a particular thought process behind why you're using a treadmill and not another modality of exercise. I'm particularly thinking about, instead of like a bike or something that may be a little bit more accessible for people recovering from chemotherapy.
So great question. We actually do, although I say we give everybody a treadmill, we really do give patients the option of, do you want a treadmill? We give patients the option of a recumbent or a stationary cycle. Some patients prefer an elliptical. Really, at the end of the day, it's about finding a tool to be able to do the exercise. And it's not about what modality you use to do the exercise. It's about that the exercise is being done. And so most people will choose the treadmill. And we know that because, at least in the United States, the preferred modality of doing activity is walking. Now, that's different. In Europe, the preferred modality is bicycling. And so for studies that are done overseas in Europe, they give away a lot of bikes. They give away less treadmills. Whereas here, we give away a lot of treadmills. We do give away some bikes and ellipticals, but really what we're trying to do is be able to give participants a tool that they can use to be able to improve their health. We don't force them to use the treadmill. The treadmill is convenient when it's either very hot or very cold out, or it's dark and you don't want to go by yourself. So we work with participants to really be able to make best use of the tool so that they can achieve the goals of the study. And then we allow them to keep it, because I tell them, by participating in a research study focused on behavior change, all of the knowledge, skills, abilities we give you, you're going to have for the rest of your life. And so my hope is that in our time working with you, we have oriented you and your health so that when the study ends, you just keep doing your thing. And that's really my hope, is that we can work through the logistics of helping patients identify an exercise type that they like, because I tell them, I want you to do it for the rest of your life, because that's the challenge with exercise. You don't get the benefit if you don't do the activity. And so I want you to find an activity you like to do and just do it. But great question.
Thank you. All right. Well, if we have no other questions, thank you again, Dr. Brown, and thank you for everyone who joined us today. As a reminder, a recording of today's session will be available in the next few days and will be shared via the CaTS listserv and posted on the CaTS YouTube channel. We hope you'll join us for future sessions, and we will announce the next speaker soon. If anyone's interested in being a speaker for the series, please contact either myself or Megan Bronson mbronson@tulane.edu or casey.lindsley@pbrc.edu. All right, thanks everyone.
Thank you all.